Welcome to our brief presentation on tips for coding hand surgeries in CPT presented by Haugen's Director of Clinical Integration, Ed O'Byrne. There are no CEUs offered with this presentation. If you are looking for education with CEUs, we encourage you to visit our online store for additional webinars and online courses. Let's hear from Ed.
Hi, this is Ed O'Byrne with Haugen Consulting Group with some useful tips in coding hand surgeries in CPT. Our hands are incredibly intricate, hand surgeries can be complex, and coding these in CPT can be challenging. So let's have a look at a few tips. A solid understanding of hand anatomy is critical to accurate CPT coding. I have to emphasize that greatly. Tendons in the hand are numerous and arranged in some unexpected ways. For flexion of the fingers, there are 2 flexor tendons to each digit. The flexor digitorum profundus is the long tendon that attaches to the distal phalanx, way down at the fingertip. Remember, profundus or profound is the long tendon. The flexor digitorum sublimis or superficialis is the shorter of the two and it inserts at the middle phalanx. It is also the shallower of the 2 tendons up to this point, when the profundus running underneath it exits through Camper's chiasm and extends down to the distal phalanx. Now together these 2 tendons allow us to selectively flex each of our fingers at the individual joints. Each finger is served by a single extensor tendon that actually originates from one common extensor tendon at the wrist that divides just as it enters the hand. But the index and small fingers each have an additional extensor tendon. The extensor indis proprius for the index finger and the extensor digiti minimi for the small finger. If you've ever noticed it's easier to do this with your hand than with the other 2 fingers, it's because of these 2 dedicated index and small finger tendons. Also remember these when coding multiple tendon procedures, both the flexors and the extensors. Let's take a look at an example. Tinalysis, which is the freeing up of tendons from scar tissue occurring from infection, inflammation, injury, ischemia, and certain other causes, is a common focus for surgery. It's very common for a hand surgeon to tinalyse multiple tendons, so it's important for us coders to know the anatomy. For example, if a surgeon tinalyses the flexors of one finger, you will likely have 2 iterations of the respective code, one for the sublimis, one for the profundus. Same for the extensor tinalysis, but only in the case of the index and little fingers. And be sure to code per the documentation. Don't assume that both tendons were tinalyzed. Make sure it's there, but just be vigilant. It also matters where the tinalysis is done, whether just the finger or just in the hand or both. So know your anatomy and read the op report thoroughly, and don't miss the opportunity to capture the coding for each tendon that's worked on. For example, a flexor tinalysis in the hand or finger with the respective anatomy modifier, finger or hand accordingly, finger or laterality accordingly, may merit up to MUE of 6. In one digit, it could involve both the FDP and the FDS, or potentially only one. With the hand and finger, the MUE is 5, and accordingly extensor tendons in just the hand or finger, or more complex extending up into the wrist. Tendon repairs for rupture or laceration can be crucial to restore useful function of the hand and fingers. Here's what you need to know about the procedure before ripping into your CPT manual or your encoder. So first have a look at the type of the tendon injury, whether it's an extensor tendon, flexor tendon, or more specific, the distal flexor digitorum profundus, which is distal to the Camper's chiasm, that is the middle part of the middle phalanx, the second phalanx out, where only the FDP tendon exists. The sublimis stops here. Second, know the timing of the repair, whether it's a primary repair or secondary, that is at the time of injury or at some point later. Secondary repairs of tendon lacerations often are done in the case where the proximal part of the tendon is retracted up into the forearm. Therefore, the third element is often more commonly needed, that is a graft, and there are codes for both with and without grafts. And then finally, in the special case of flexor tendons, whether the laceration is in zone 2 or no man's land, which exists from the distal palmar crease, where the A1 pulley starts, and goes down to where the profundus tendon exits from beneath the sublimis tendon. In this area, both flexor tendons pass through the flexor tendon sheath. Therefore, it's critically important that the repair be very precise and free it from scarring and adhesions because of that tight fit in there. So because that surgery is much harder, consequently there is a specialized CPT code for it. Dupuytrens contracture is a condition where the palmar fascia in the hand contracts down into a tightened band, often at the base of one digit, but it can be more. This is more common in people of Northern European ancestry and is consequently sometimes called Viking's disease, colloquially. Certain risk factors are smoking and a thin habitus, and if you're of my age and you remember back in the 80s, the Gipper was running around for a while with one of these himself in his left hand there, waving at the media and smiling like he always did. So here's what that looks like up close. There's a palmar band pulling the finger into flexion, which is just, it's kind of inconvenient in the way. So there are ways, fortunately, to treat this. A surgeon may term any number of procedures for Dupuytren's contracture a palmar fascial release, including an enzyme injection and manipulation, for which there are CPT codes. But let's talk about the more invasive surgeries. Now, fasciotomy involves cutting through the constricting band, either open or percutaneous, and not surprisingly, there is a code for each of these. Fasciectomy is actually cutting out of the palmar band, and it is always consequently open. It's more decisive, and it has less of a chance of recurrence. Now, there's a subtle difference in the anatomy of a fasciectomy as to whether the release is just in the hand or in the finger too. Now, happily, for us as coders, these fasciectomy codes make it easy as they include skin flaps and grafts, which is unusual in CPT, that they make it easy on us by including those in. But it's not uncommon to have to rearrange the skin around the closure of a Dupuytren's contracture to allow closure and allow that skin to come out to full stretch. Your hands have 27 bones each, which totals a quarter of the bones in your whole body. Take time to get to know each of these well if you code hand surgeries, and keep a diagram like the one you see nearby when you're coding these. The CPT codes you'll encounter are highly specific to each bone and joint type, and there are a number of fractures and dislocations that can occur in the hand. And compared to the rest of the skeleton, such injuries in the hand are more likely to require surgery, due in part to the precision alignment needed for useful finger movements. Hand and finger fractures and dislocations can be treated sometimes percutaneously with a K-wire or Kirschner wire, which is drilled through the skin and into the bone and then across the fracture, keeping the bone in alignment while it heals. To prevent spinning of the fragments upon a single wire, often two wires will be placed, but there's only one fracture, so only one code. Here are some examples. Based on the location of the fracture in the distal phalanx or other phalanx, middle or proximal phalanx, we have a difference in CPT codes as well as in the metacarpal fracture, zone 26608. Here is an example of a proximal phalanx fracture of the thumb requiring two K-wires, or in the distal phalanx, only one is drilled in distally across the fracture fragment and oftentimes through the adjacent joint as well. Here's a fifth metacarpal fracture that may require pinning, although notice that carpal fractures, when pinned, do not have a CPT code, so we would use the unlisted. Fortunately, those aren't as commonly treated with pinning, but now you know, use the unlisted code. And don't forget your finger modifiers for phalanx fractures and your laterality right or left modifier for carpal and metacarpal fractures. Now, dislocations are a little bit different. It's right down to the specific joint, but it does actually include the carpometacarpal joint. So the carpals come into play there, and the other options are metacarpophalangeal or interphalangeal when dislocated. Now, open fracture treatment, commonly referred to as an ORIF or ORIF, may be needed when the reduction of the fracture is difficult or when a stronger construct is needed, or it's a more complex fracture to get the pieces together. Take note, the CPT codes for open fracture are predicated only on the open exposure of the site. In other words, visualization of the bone and fracture, and not on the hardware used. In fact, K-wires can be used in an open fracture care, but more commonly plates and screws, as you see, are used to hold the fracture in place. For shaft fractures, it's down to the specific bone. For articular fractures, open treatment is all under one code. So you'll see an open treatment of a distal phalanx fracture, a middle or proximal phalanx fracture, or a metacarpal fracture are all different from one another. However, an articular fracture from the metacarpophalangeal down is 26746. Now, read your op report carefully, and if the x-rays are available for you to have a look, I recommend having a look. It can only help you better understand what you're coding. So thanks for joining us on this set of quick tips in coding hand surgery and CPT. These can be challenging, but also fun if you're comfortable with the anatomy and you read the op report carefully, or if you're like me, 2 or 3 or 4 times. This has been Ed O'Byrne from the Haugen Consulting Group, and we'll see you next time. Take care of your hands.
Thank you for joining us. Make sure to subscribe to our blog and YouTube channel for additional free resources. We'll see you soon.